Kia ora, everyone. Welcome to this Goodfellow Unit webinar. Tonight we are talking on adolescent youth health using the HEADDSSS assessment in our consults and how we can best manage our Māori and Pacific youth and our cultural competency around this. Tonight we have Dr. Aniva Lawrence speaking with us. So without further ado, I'd like to introduce Aniva, who's our expert speaker tonight. She's a general practitioner in Northland, coming to us from Northland this evening. She is the current clinical director of primary care for Northland and has done a large amount of research and work within youth and adolescent health, both in New Zealand and overseas. So welcome, Aniva.
Thanks, Helen.
Now I'll pass it over to you to start the talk for tonight.
Hi everyone, talofa lava, tēnā koutou, tēnā koutou katoa. And I guess my interest in youth health was tweaked when I was at medical school, and I was able to do my 4-week elective with Peter Watson and Vicky Shaw, who was a GP who specialised in youth health at the Centre for Youth Health down in South Auckland at that time. And that really triggered my interest in adolescent health, which enabled me to do my elective over in Melbourne with Suzanne Sawyer, who's now one of the head WHO leads in adolescent health, and she's an adolescent respiratory physician. So, and from there, when I started working in general practice in 2011, I got the opportunity. Vodafone sponsored me to do a fellowship overseas, and I spent some time in Canada on Vancouver Island looking at Indigenous youth health, and then going from there over to Minnesota to do a summer school in resilience in adolescents, and then finally ended up down in LA and spent some time with the creators of HEADDSSS. So that was really, I think, where my learnings were refined as such, and hopefully I'll be able to share some of that with you tonight, and just really around my years of experience of working with young people, particularly Māori and Pacific young people, and the things that I find that work within general practice and within that 50-minute consultation. So I usually share a photo of my kids, and these are my oldest 2 teenagers at the moment, and so hopefully I don't put you to sleep like they often do when we go on a long drive. This is probably a drive just from Whangarei to Auckland, so only 2 hours. But yes, sleep is very important in adolescence, and what I'm going to do is share a lot of research from the University of Auckland's work, and so I have to kind of give some acknowledgement and thanks to a good friend of mine and colleague, Dr. Terry Ann Clark, for sharing some of her research that involves specifically Māori youth. And her and Simon Denny have obviously done the Youth 2000 survey, which is a really important piece of research that has a cohort study of young people here within New Zealand. So the reason I chose youth health are the following the reasons, and I find that within general practice that I'm able to help transition, and actually it's a real benefit for me as a GP to see success and to see healthy adults come from sometimes quite unhealthy teenagers, and understanding how their early, middle and late adolescence impacts, and that development impacts on their brains and on the way that they're doing decision making, helps me to understand how to taper things to them, so, and cater for their needs at any given time. So hopefully you'll learn some of this tonight too. So I'll give you a little bit of information around the Youth 2000 series, and there have been 3 big cohorts done on secondary school students across the country. That was in 2000, 2007, and then 2012. They've also done studies which have looked at alternative education students, and a teen parent unit survey as well. And then in 2007, they did a specific whare kura survey, which is those who are in full immersion, kura kaupapa. It's quite a cutting edge piece of research, really. Internationally, we're quite well recognised because back in 2000, we started off, the team started off using laptops, and from that point went to kind of handheld devices with styluses in 2007, and now obviously tablets with headphones that can be done anywhere, really. So the technology has evolved as quickly as the survey has evolved. But this is just some of the characteristics of the survey in regards to demographics. So you can see that it's probably the largest cohort of Māori rangatahi that has been done to date in New Zealand, and good numbers of Pacific students participating as well too. So a lot of the information that I'm going to share with you tonight is results from breakdowns of these surveys. So in this last 2012 literature, this is a really sometimes confusing diagram to look at, but actually I find it really easy as a GP, because basically you look for green or red, and green is good. It means that young people have made positive gains between 2000 and 2012. And red means that actually we're not doing so well. We've actually had negative impact in our young people from those years to now. And so this is helpful for us to know kind of what our emphasis should be. So we've done really well with education, drugs and alcohol, driving and violence across the board with young people, but really pay attention to those things that are particularly important for us as GPs, like access to healthcare, parental time, emotional well-being, and condom use and contraception hasn't really changed. So summarising that, it's really showing that this younger generation, these Gen Zs, are leading the way. They're becoming healthier and making healthier decisions. However, we know that we need to have these strategies that are sustained to impact on what we're seeing in these cohorts, but also need to have clear priority areas for policy and for us to work on within general practice as well. So particularly around contraception and condom use, bullying, being overweight and experiencing depressive symptoms. So we really need to have an emphasis around better access to primary health care, about having good, affordable, healthy food available to our teams, and giving them employment opportunities, because that's definitely dropped off. So if we look at HEADDSS, most of you, I gather, are familiar with HEADDSS. And obviously, I want to just remind, as I do my registrars, that HEADDSS is an engagement tool. It is not a screening tool. Even though the government is still funding this to be done in a screening tool way, actually for us as providers, it was developed in LA actually to present youth cases in a systematic way. So it wasn't about the way that you screened a young person, it was about how you engaged with them, how you kind of addressed non-threatening topics first, and then moved towards those that were maybe going to make them feel a little bit more uncomfortable talking about it. It also is an opportunity to, you know, if a parent is with them, give them the opportunity to exit the room when you're going to touch on those things that are a bit more sensitive. So I usually, people ask me, how do you do that? And I can remember having a nanny who came in with her mokopuna, and she was very staunch and she was adamant she wasn't going to leave the room at all. And so in that case, I had to do a urine sample anyway, and I did the rest of my HEADDSS as we were talking in the bathroom, private bathroom area. And so there are things that you can do to kind of get around those that are putting their foot down and saying they're not going to leave the room. But most parents actually, I say, I like young people that I see as they're getting older to become more confident in talking to the doctor by themselves, so that they might be able to come in and feel like they can see me with anything going forward. So most parents accept that and actually are happy to kind of give you some time with the young person individually. But yeah, that's just a refresher on what you're wanting to look at. I also talk about how you ask the question. So I really, I always say it's often, even when you're getting to more sensitive questions, you want to ask a young person, get an idea of where they're at, because they may not be a smoker, but I usually will say, do any of your mates smoke? And they might say, oh yeah, I've got some that are smokers. And that gives you a kind of an insight into not just what their behaviours are, but what their peer group behaviours are and other people around them. So often you can start with an external person, which is less threatening, and then ask them individually what's going on for them.
Aniva, the very first question that's come through tonight has been about how you start or warm up a conversation with teenagers, given that they're not always open with someone they don't know well or haven't met before. So I think you've given some great examples there already. Is there anything else that you would particularly add to that in terms of opening the conversation before you start on the rest of the assessment?
I think it's always important to ask them if they've ever been seen by a GP by themselves before. I usually go through their understanding around confidentiality and privacy, and understanding that actually we've got a private time for us to talk together. You know, we talk about what the things are that we can talk about that are going to be kept private, but the exceptions to the rule as well too. So the four harms really, and the things legally that we can't keep to ourselves and that we have to involve someone else. But I always reassure the young person as well at that time that this will be done in consultation with them, so that they know who exactly is going to be involved, and it's not going to be done to them, it's going to be done with them. In that sense, if they do talk about something that is where they're being harm has been happening to someone that they know, they're going to harm someone, or they're going to harm themselves. So yeah. Okay.
And, sorry, one more question that's come through. On the basis of that, do you ever offer to not record a response as to whether they take illicit drugs or not, in terms of your, I guess, your records on the day?
Records on the day. Yeah, I mean, I think what I usually do in consultation with the young person is that we talk about keeping their records confidential. So you have the ability within your patient management system, so that you can make it so that no other colleagues or people within the clinic can see what you've written on that day as well too, because ultimately you often as a person want to know or remind yourselves, if you're seeing a lot of young people as well too, of what's actually going on for them. So most young people are happy with that in regards to their drug use.
Great, thank you.
So kind of the things that I do in terms of adapting a HEADDSS assessment to think about those who are Māori and Pacific are coming to see me, is that really home is, you know, traditionally it's who are you living with? That's our kind of opening question, and then it gives them the breadth to talk a lot about, you know, their home environment and stuff, not necessarily assuming that it's in a you know, a traditional setting or with immediate family either, but really with Māori and Pacifica youth, you really do have to widen that around talking about extended whānau connections. Are they connected to their marae that they affiliate with, and it may be a couple of maraes as well too. Whaalavelave is a Samoan thing that can sometimes impact quite heavily on younger Pacific New Zealanders as well, and that's the Samoan term for it, but every island has its own word for it, and it really is around the financial commitment that you make to your extended family that are usually back in the islands, and that may be in regards to who in your family holds chiefly titles and things like that. So this can be for times of funerals or weddings or family events that there is often extra financial burden on people who live within New Zealand. So it's important to talk about that and what impact that might be having on home situations. Also, in terms of I kind of add aspirations, and it comes in nicely after education and employment, and you can talk about where they're at, but I actually like to talk about Māori with Māori and Pacifica youth about what their aspirations are, because it might be interesting to hear what their own aspirations are versus what their aspirations of their whānau are as well too for them. So, and along with activities, you must always talk about church or religion, particularly in Polynesian culture. That's quite a key aspect to our weekly routines and lives as well too. Often young people will be attending church throughout the week, as not just on the weekend. And then obviously tangihanga, or the process of funerals for Māori, is often again not just the funeral service as in traditional European cultures. It is a 3-day process, and there is kaupapa around that. So, and that can also involve reunions are quite heavily important to Māori and Pacifica families as well too. So often a lot of time and energy will go into creating big extended family reunions, and young people will often have their t-shirts or things that have been created, you know, often whānau go really full on into that. So there's, yeah, a funny story, but I won't. If we have time, I'll tell about the reunion story later. For diet, the important thing is traditional foods is not expecting that. There was a piece of research done some time ago, which was Big Mac versus Pisupu, which is corned beef, and this is the struggle in terms of again, New Zealand-born Pacific people, or those who are second or third generation Pacific, where our parents and our grandparents are still heavily involved in participating from a cultural perspective and food choices, whereas sometimes there's this shift as well too when you've suddenly got KFC down the road, or pies at the local dairy and things like that. And I guess the thing is too, in traditional Pacific culture, everyone walks, not many people have cars in the Pacific as well too. So your local village shop is where you get everything from. So this is the thing around dairies right next to schools and stuff like that. That is highly used by our teenagers, and it's a hard one when they're, you know, a lot more in our low decile communities than there are in, say, our higher decile and next to our higher decile schools. So I put ceremonial expectations around here too, because so I'll use an experience that I have a Tongan sister-in-law, and so my culture is Samoan, but I have Tongan sister-in-laws, Cook Island sister-in-law, Niuean brother-in-law. The family is big anyway. So and in Tongan culture, my sister-in-law, I'm the oldest sister of her husband, who's my brother, and as the oldest sister, it's a very matriarchal culture, in the sense that actually the oldest sister is the most respected. So, and first birthdays are big. So, you know, in Polynesian culture, actually a first birthday might be bigger than, say, a third or a fourth. And at this time, you know, I'd come in and I was pulled over by my sister-in-law's parents and brought to the main table, and the main table had food that was piled 6 or 7 layers high, and they were like, "Eat, Aniva," and I was like, you know, and culturally you cannot not eat in the sense, because they have created this for you in terms of your role and your fit within that cultural society and stuff. And so you know, I asked if my parents could sit with me, and out of respect, and they came, and then it's good to be able to show that you're trying all the different things that they have created for you, because that is part of their love, and you in return show your love and appreciation by demonstrating that. And so that's probably the best way for me to explain ceremonial expectation around food and how culturally significant that is for Polynesians. Obviously, from a Samoan culture, if you've ever attended a Samoan wedding, not just the exchange of mats, but there is exchange of food as part of that ceremony, and so that's quite a common thing to see and experience when you're participating in ceremonies of Pacific culture. And again, Māori culture, because hakari is kind of, there are some similarities, but there are definitely differences as well too. For drugs and alcohol, definitely cannabis. We, back in the 2007 data, we looked at Northland data specifically. We kind of paid to do some research on that, and our young people using cannabis higher than smoking. And I think it's probably going to be the same as we go forward as well too, in regards to normal cigarettes are becoming more expensive. And so in that sense, cannabis becomes cheaper. And so there was a big issue with synthetic cannabis as well too, in terms of it being cheaper for a period of time, and there was, again, still issues around those that were addicted while it was more accessible and not in the black market, but it's still present and out there, as we've seen in terms of recent hospitalisations down in the South Island. So,
and Aniva, sorry, someone's just asked what is your suggestion of discussing cannabis use with the teen where the parents and extended family are regular cannabis users themselves?
I think it's really just educating in regard, because not a lot of myths still exist in regards to cannabis around it being natural, and you know, again, they often look at the stuff that's coming out around medicinal cannabinoids as well, and you know, so the latest thing I've heard from teenagers is that it's, you know, great for pain and great for you know, aches and pains and things like that. So I think it's making sure that they're aware also of the realities around harmful effect. I've seen, you know, and I do talk about the youngest Māori male I've seen with emphysema is 30, who was a heavy cannabis smoker, and I think that they don't understand around particles, and they do when you talk it in plain terms, that if you talk to them about particle size, effect on the lungs, damaging the lungs faster than normal cigarettes that are using filtration, they kind of understand those concepts, and when you can talk about it in that sense and educate them around that, then sometimes that can have impact. But it is really difficult. Yeah, there's multi-generational. It's really funny. I saw a whānau that, you know, parents were regular users, and they brought in 13-year-old because they didn't want the 13-year-old using. Oh. And I think that, you know, this is the thing in terms of do what I say, not what I do, as well too.
With
and so for us, and we actually had to do a lot of work with the parents around, because for them to see that actually for their young person to be well and healthy, they also needed to demonstrate and be modelling healthy lifestyles and healthy behaviours and stuff as well too. So I put kava in there as well, particularly so in Samoan, Fiji, Tongan communities, this is quite a significant issue as well too. There's a public health specialist in Fiji who did some research around the impact of kava on motor vehicle accidents. So it's probably higher risk than alcohol use in Fiji, and I think that again, you need to be kava is used in traditional ceremonial ways, but it is also used as a drug of abuse by some people as well too. So definitely screening for that in your Pacifica patients. The sex question is around, I'm not going to do too much on sex tonight, but I wanted to highlight sex trafficking, which I'll talk a little bit about later. There's again quite an interesting PhD student at the moment who's about to publish, who's done quite a bit of research into this in New Zealand, and I'll touch on that in some of my later slides. Really, it's important for you to assess knowledge adequately. In Polynesian culture, I'm talking about Pacific Island probably more so than Māori, is that you don't talk about it. I mean, so much so that, again, I'm thinking from a Tongan culture perspective, brothers and sisters can't even talk about it together. So it is quite, sometimes the knowledge or understanding may have come from sources that may not be so reliable, and I'll talk a little bit about that as well too later in the presentation. So you don't want to just, when you're screening around suicide as well too, you don't want to just ask about the present. Always remember to ask. The way I term it is if you often can get them to rank mood, and like from a 1 to 10, how if 1 was feeling crap and feeling like you wanted your life to end, and 10 was great, no problems at all, where do you put yourself? And most young people, commonly will tell me 6 to 8, and I'll say, okay, that's great. Have you ever felt like a 2 or a 3? And a lot of them will tell you quite frankly, yes, and what made them feel that way and when it was, and things like that. So it's an easy, quick way to kind of assess that. The other thing is to extend beyond self and think about those that they might have been impacted on or affected in terms of suicide. I'm going to talk about suicide a little bit later as well too, so I won't go much more into that now. From a safety perspective, and safety is often the question that's left off or forgotten about, but actually in New Zealand it's still the biggest cause of mortality for young people. Most young people that die under the age of 25 are dying because of motor vehicle accidents or non-accidental injury due to violence. So I think the important thing is to be asking around it, and asking around family violence as well too, and teenagers will quite frankly tell you that, and also around our obligations to teenagers as well too. They often will come to us because they're seeking refuge and they're seeking help and support in terms of becoming safe. So we really need to acknowledge that. I put in there a salu because it's again language. A salu was a broom that it's actually a broom that's made out of like a plant material. But yeah, that's a common thing that you can get across the legs in Samoan culture. So yeah, again, language-wise, you may need to. They might say, yeah, I get the salu all the time. But you may be like, what's a salu? Just ask young people, if you don't understand what they're telling you about, ask them, what are you meaning by that? And they'll explain it to you again. So, and the driving is particularly in our rural youth. So, many of our Māori youth live rurally, and often they will start driving very early, either on the farm and things, and that will extend out onto the road, not necessarily licensed, and sometimes that can end them up in tricky situations as well too, where they're actually probably quite good drivers, but just haven't gone that next step of actually licensing themselves. And there's again another friend of mine who I trained with, Omir Herman, has done a piece of research in the Cook Islands which actually helped change policy. So they realized they wanted to try and legalize helmets because everyone drives scooters over in the Cook Islands, but they were getting all this resistance from all the communities, the elderly ladies that travel to church 20 k's an hour down the road they didn't want to wear a helmet because it would mess their Sunday best hats and things that they were wearing to church, and there was actually outrage and protests when this policy was trying to be implemented from a Ministry of Health perspective. So they looked closer at the data and they realized that all the accidents were happening in their under 25-year-olds. So the way that they passed the law, the way that they changed the policy, was restricting that helmet wearing being to when you first get your license all the way up to your age 25. So having an age limit on it was how that they were able to pass it within their government. So there is really implications for public health things, and that may be different to New Zealand versus in the Pacific communities. But how do we do it all in 15 minutes? Remembering, as GPs, we are continuity of care environment. We're an environment where we have the opportunity to see people ongoing. We get to know their families. We get to know how they fit within their communities. It really doesn't have to be done in a 15-minute consult. So I might ask a couple of questions depending on what they've come in with. You know, like they may have come in with a strep throat, and actually that's taken me 5 minutes. So let's kind of explore things and ask a few more questions and just see where things are at. It really does take, you know, we know that analogy that it takes a village to raise a child. Like it does, actually it takes a team of people to help a teen transition healthily into adulthood. So really using your members of your team, and you may have a passionate nurse that's really interested in young people. You may have a healthcare assistant or an administrator that just clicks with your young people as well too. So often you can use your wider team to actually develop those relationships and build that rapport with your teenagers. It's really important to have accurate documentation so that, yes, your colleagues that might see them if you're not there can know what you've covered, and that they can pick up where you've left off, so that if you haven't asked, you know, full screening questions, they can kind of go from there and not ask necessarily the same things. They can touch base if there's things of risk, but it enables you to develop a heads or get a heads done over a period of time with a young person. We also have to repeat questions, definitely, because a 13-year-old is much different from a 17-year-old. Some people I know have done kind of free health checks for, like one of the initiatives that we're thinking is around school holidays, bringing in our 13 and now 14, well, 14-year-olds with them becoming free on the 1st of December, but before they become not free, actually using a consult to really see how they're going, try and do kind of a baseline heads for them, and have that as a lead in to them then needing, obviously going to be having to pay co-payments as they go forward and become older. I guess it's important to invite them back if you've got some really concerning things as well too. All the times that I've asked around parents or whānau that have been with the young person, if it's all right to have a longer appointment with the young person, they've all said yes. No one's ever kind of said, oh, no, I can't, you know, I'm not going to, I can't afford that, or I'm not going to bring this young person back. Genuinely, all the parents actually want really good health care for the young person as well too. So just offering that to the families is a proactive way of engaging with your adolescents. So talking specifically about Māori rangatahi. So if we look at that same diagram that we did for all youth in New Zealand, if we look at Māori, there are a couple of areas obviously in the top, which is Te Ao Māori, which only Māori answer, but the rest are the same as everyone else. And if you'll see there that there are slight differences. So definitely general practice access, employment, worry about food, again, overweight, obese, and depression, and particularly having enough time with parents. And that you'll see there's been no change around school adults that care as well too. So we'll talk a little bit more about why or what might be going on here. So the positive things are that actually the majority of our tamariki Māori know who they are affiliated to, and they're really proud to be Māori within New Zealand. So they are increasingly in numbers understanding Te Reo Māori, but also starting to speak and become more confident in terms of conversing in Te Reo Māori and posting in Te Reo Māori, which is really exciting to see young people having conversations on social media completely in Te Reo. With whānau, obviously, there is really good connections. They do have positive interactions, that they feel like their parents care about them. They do have close relationships with our parent. Having fun with their family and having enough time with their family is what's the lowest at the moment. So, and I think as increasing westernized society has come in with an increasing lifestyle around work and financially being secure and things like that, we're probably seeing a drop-off in terms of how much time young people are getting with their parents. And it is an increasing time. I say to parents often, you know, parents say they hit 14, yeah, I can leave them by themselves. It's actually the time where you want to be more involved in regards to having time with them. So in our social economic environment for Māori, if you look comparatively between Māori and New Zealand, European Pākehā, we know that they're in higher deprivation areas. So it looks like a reverse graph if you look at European versus Māori, like 45% Pākehā in low deprivation areas, 46 for Māori are in high deprivation areas. So this is the stark difference. There is a significant number that are really saying that there's worry about not enough food to eat at home, and definitely overcrowding occurs for both Māori and Pacifica families as well too. And school, generally most students are feeling safe at school. If you look at that 86%, there's a proportion that don't, and 6% of those young people are reporting bullying occurring, and only 25% report that teachers care about them a lot. So there's still a bit of room to move really from an educational perspective around understanding what these statistics are saying. And we have seen gains. If you look at that school completion, we're seeing the gap narrowing, and it is coming closer, but the difficulty is that as we get gains for Māori, we also get gains for New Zealand European. So we know what works in terms of improving Māori also improves things for the general population. And this is an important graph because we've talked about this already, but if you look, and this is important in the sense that general practitioners are still 80% of where young Māori will attend, and definitely better for those that are low deprivation young Māori. So like my children, for example, no problems about getting into a general practitioner. However, if you look at high dep youth, and in 2011 I did some research around this, and it found that 63% of young people accessing school-based health services are Māori. So actually our low deprivation youth are highly seeking care from school-based health services versus mainstream general practice. So you can see that here on this column there, and we expect that that will increase. This is every cohort we look at this, and this is the 2012 data. So it's changed quite significantly from 2000 when there were hardly any school-based health services. It was only in 2001 that we were even establishing school-based health services here in Northland. We should see this change as we become more, increase our access.
And Eva, if you just hold it there for 1 second, we've just had a few people come in and say they can't see the charts that you're referring to. So I just want to check with our IT person if that is still working and if it's still working on your screen, Aniva.
It's working from my screen.
Yeah.
All these graphs will be available, so you can look, you know, we can load.
They come up on the website afterwards.
Yeah,
and I think there's now a few people, looks like it's coming through now. Most people are seeing them fine. If you're on a phone, just remember if you slide sideways on your phone. So on one screen you will see the faces, on the other screen you'll see the slide set. So if you slide sideways, you'll be able to go back and forth between the two. You unfortunately can't see us and the slide set on your phone unless you're on your computer. And here we go. People are coming in saying they can see it fine. So I'll let you continue. I just wanted to check that people were doing okay there.
That's all right. That's great. Okay then.
Thanks.
So before we start looking at kind of risk-taking behaviours, remember there is a divide between urban youth and rural youth, and we do need to. There are things that I think I'm just going to touch on here, which will impact in terms of what you're about to learn around rangatahi Māori, and it's particularly and. I haven't incorporated this into heads because I think this is around our own understanding and our own knowledge that we bring to our practice and our clinical practice each day. We really need to have an understanding around Te Tiriti o Waitangi and the Māori Land Wars and Tōhanga Suppression Act and all the other acts that have come since then around that have been discriminative, particularly to Māori whānau. And I think that those things have impacted into multi-generational trauma. There are young people that hold really fixed understandings and beliefs from intergenerationally, which they totally understand, but we as providers may not understand. So it's really important to gain some understanding to know where they're coming from and why this may impact from them. And don't be judgmental of their cultural difference either, because that's not everyone's different. We all have cultural differences. And so again, it's coming to a place where you can feel comfortable in that and in your own understanding of things. Discrimination and racism, it's still alive and well. I was at a petrol station on the weekend, and my sister-in-law was in the car with me. A car pulled out. There was only one pump. I pulled into the pump, got out and started filling my car. And a lovely elderly gentleman who happened to be European came out of the petrol station and said, "What are you doing? You saw I was parked this way. I need to get out." And I was like, "This is the only pump." and he said, "Well, just hurry up." And I said, "You've got no one behind you." And then promptly, couldn't hurry the pump up anymore, but went into the service station, and this attendant in the service station said, "Are you all right?" And I said, "Yes, I'm all right." And he was like, he seemed to be in a very big rush. And I said, "Yes, but that doesn't excuse bad behaviour." and so I think that this is the thing in terms of, this was just on the weekend for me. This is just something that young people of colour in New Zealand still experience quite regularly. And I think the difficulty is that how that impacts. So I'm going to talk a little bit now around that. So we talk about sexual and reproductive health, and we know that condom use and contraception use haven't really changed, and really this is around access. For us, we keep condoms in our bathroom for anyone to take, and basically, you can get 144 in an MPSO. We should be more widely distributing this so that people are having safe sex, and definitely there has been a piece of research done around contraception as well too, and again some of the cultural beliefs that are behind around what contraception is, because it is a westernized medicine, that actually what is that doing in regards to fertility and whakapapa and all of the cultural things that impact for Māori. So overcoming some of these barriers and stuff, and understanding of where their beliefs come from, can be helpful in terms of how you can make things more accessible or more appropriate or more acceptable to younger people that are culturally different, culturally Māori or Pacifica. Substance use, we've talked a little bit about that. Smoking's improving, which is great. If you can see those years, it's coming down. Alcohol, again, a little bit different in 2012. It'll be interesting to see next year. There's a new cohort being done next year. So, and we are getting reduction around marijuana use, even though, like we said, sometimes it's going to be higher than cigarette use. And then violence, just being aware of that in terms of those who've witnessed other adults hitting other adults at home, and those who've witnessed adults hitting children as well too. So there are disparities, and I won't go through all of these, but I'll give you some time to read through them. Young people are less likely to report those on the left that are Māori, but they're more likely to report those that are on the right. And so there are definite disparities between non-Māori and Māori. And it was really nice to have the conference, having a focus around equity, and to listen to Kamara Jones, who is so well regarded in regards to the research that she did in New Zealand around racism and discrimination. And so we aren't really seeing any change in disparities at this point in time, other than for these following things. So we are seeing some improvement or some narrowing in the following list as well too. So that is a positive. It means, from my mind, that things can change and things can get better. And there are definitely, if you look at these things, there have been significant health promotion programs and significant things like DARE in high schools, you know, around raising awareness and changing behaviours. So things that are often instigated by young people themselves. There are some great projects around reduced bullying where young people themselves have become the leaders in their own communities and driving change. So I'm going to focus more specifically on depression and suicide for Māori. And this is particularly a big and current thing within Northland. Many of you will understand that we've been having spikes of youth suicides in regards, and particularly for Māori youth. And I think the important thing is to understand again what we know from a research perspective about how's this been impacted and what's the influencing or driving factors behind this. So for Māori versus Pākehā in New Zealand, we can see the change in regards to reduced levels of depression. It's kind of static, but overall improved as such. But for suicide attempts, the biggest thing for you to understand is that suicide attempts are still double in Māori as non-Māori. And this is a really complex, and I was warned that some might not show up on the screen, but again, if you can look at this later and just take some time to look at the ultimate causes, distal causes, proximal causes, which lead to positive, negative experiences, and then risk-taking behaviour or healthy behaviours. And they're influenced, again, socially, attitudinally, and intrapersonally. So these are all the things that can kind of make up where a young person might be that's coming to see you in clinic and sitting in front of you. Are there any questions specifically about that? I know it's a very complex graph, but we're going to carry on.
I think there has been just one question, will it be available later?
Sure.
And yes, this whole webinar and all the slides will be up on the website tomorrow, as soon as we load it up. And so you'll be able to look at that and go through any of the slides and anything that Aniva is saying down the track. So everything will be available to all. There are a couple of other questions, but we might come to them once you've got to the end of what you're doing next, I think, Aniva. We'll carry on for now. Yeah.
I think so, because this is around some more specific research that's done particularly about Māori. Yeah. So we can it may answer some of your questions that you have. So this was a piece of work that was done around the original 2000 data, and this was looking at what moderates suicide for Māori specifically. And at that stage, there was no moderating of strengthening relationships between family connection and suicide attempts. So they looked a little bit wider, and they did find what happened was more of a compensatory process. So kind of things kicked in when required, and as you had more protective factors, you'll reduce. You did get reduction of suicide attempts, but so even if your risk factors were very high, you do get a compensatory process where you can actually reduce your risk of suicide. There's been another more recent piece of research looking, so this was a summer studentship done by a University of Auckland student under Dr. Terry Ann Clark, and they were happy to share this with you. This has just come out this year, and it is around looking at whether there are cultural identity markers and whether ethnic discrimination impacts on mental health outcomes for particularly rangatahi Māori. And so they looked at this big cohort. They did a logistic regression model and looked at the depression scores and then suicide attempts in the previous 12 months. and compared that. So they also looked at the Māori cultural identity scale, which is used within the cohort study. So it's an 8-item score for te reo, tikanga Māori and participation within culture, and then 6-item score for ko wai o, pride, identity and recognition as Māori. So those were classified as having strong cultural identity if they scored 8 or more in that range from 0 to 14. So that median is around 7. So the reports showed that actually those generally Māori young people report really good well-being. So their WHO 5 scale was really great. However, again, a good proportion, 13.9%, reported the significant depressive symptoms, and again, 6.5 had reported a suicide attempt in the last 12 months. A large number had experienced discrimination, and that was by teachers, health professionals, and the police. And from this piece of research, they found that ethnic discrimination was associated statistically significantly with poorer well-being scores, greater depressive symptoms, and higher suicide attempts in the last 12 months. Once they actually adjusted for age, sex, ethnic discrimination, and deprivation level, cultural identity alone was associated with improved well-being scores and less depressive symptoms. So if you looked at gender breakdowns, Māori who are males were more likely than females that had stronger cultural identities, had much more improved well-being, much less depressive symptoms, and less suicide attempts. So there wasn't any statistical significance for Māori females, and we're not sure about why, but for Māori males, there is impactful significance around cultural identity. Also, those who are thinking around developmentally, what happens for young people from a brain development perspective, yes, those aged 14 and 15 were again more significantly likely to have depressive symptoms. So really the summary from this piece of research is that it's really important to reduce discrimination and strengthen Māori in their cultural identities so that we can see significant mental health gains going forward. What we need to understand is why were Māori females not as impacted as Māori males, and also the implications around treatment and prevention, particularly around reducing suicide for Māori young people. So it's really important, the discussions and the talks that we heard from Kamara are so applicable in this space, and how if we address systemic racism and discrimination, we can actually be impactful in terms of improving Māori well-being, and that we really need more qualitative and quantitative research around this, around why is it that having cultural identity is protective. Did you want to, this is a little gap, I'm going to move on to Pacific Health. So did you have questions there, Helen, that you
there were a couple of very quick questions actually just back about the HEADDSSS assessment, and actually some comments about school-based nurses being very good at using HEADDSSS assessments, and they have obviously that contact, and it's one of their priorities that they use in their clinics. Could GPs have a better relationship with the school nurses in terms of understanding the heads for a particular patient, or sharing some information there? And also with the HEADDSSS assessment, someone has asked whether you think the scoring risk or resiliency is outdated now.
There are some tools that are still being useful. Most of the youth one-stop shops use a digital tool called Tom, which actually automatically allocates kind of risk profiling and resiliency profiling for your young people that they're working with. So, but it's only being used in youth one-stop shops at this stage. I think it is really important in terms of having those relationships. We made it intentional that we could be able to share information with a young person's GP if they were wanting that to be done from a school-based health perspective. So if they do want that assessment, it can be health linked. So our health services, and you will find this around the place, that most of our youth health services have an EDI address or are based on a patient management system themselves. So the ability to work more seamlessly as a team is accessible within many of our established school-based health services. I think definitely the adolescent specialist nurses, that continuity, again, they're developing these really strong relationships with these young people throughout their years of high school, just as we develop strong relationships with people from birth to death in that sense. So yeah, it's again that team environment of using your wider team.
Yes, yeah, like you said, yeah. And no, I think let's carry on with Pacific Youth, and we'll get to some of the questions carrying on after that.
Okay, so Pacific Youth, these are not all the same. I've talked a little bit about it in regards to, and I'm not an expert. I can't really talk about Fijian culture, Tahitian culture, Vanuatu. It is really those that come from those islands themselves have a deeper understanding of their cultural heritage and their histories and things. So taking this into consideration, we do know that the cohort studies told us about Pacific youth, and over 700 in each cohort is a great number to understand what's going on for young Pacifica people within New Zealand. And most of the issues are the same, and many of them are the same for Pacifica youth as they are for Māori, but there are some slight differences which are listed there around Cook Islands versus Samoans. And you have to be careful though in terms of once you start breaking down into individual islands, that the numbers get smaller, and so the quality of data also loses its effectiveness. But the majority of our Pacific communities are in cities or large urban areas, and there is also mainly in our communities with high deprivation. And basically, most of our young people that are Pacifica attend low to middle decile schools. We find that, again, the same things that have happened for Māori, but this slight difference or significance is that 36% said that someone at home sleeps in a room not designated for sleeping, either in a garage or a living room. And this is around overcrowding and the risks that comes with from a health and wellness perspective. So I've just put a little bit, because the educational data was a little bit more recent from the New Zealand Child and Youth Epidemiologic Service, which releases reports, and their one went up to 2013, so through the University of Otago. But again, it's showing positive gains around education for Pacifica students. So Pacifica students are often actually making greater gains than Māori within New Zealand, and so that may be, it's trying to understand around why that might be. However, again, making gains at secondary school doesn't necessarily transition into tertiary education, and so it's quite a low percentage of Pacific youth go on to tertiary level education and bachelor's level degree compared to non-Māori, non-Pacifica youth. And there's been improvements made as well too, similar, I guess, to those that that were made in the general overall youth and for Māori. But again, there's worsening in the areas that we've talked about again. And obesity and overweight, recently I did a clinic over in Samoa and I saw all women bar 3 males, and only one patient out of all of the patients that I saw had a BMI less than 35. And I guess this is the difficulty around moving away from traditional living and what westernized living has done for Pacific communities, and that is definitely impacting on our levels of diabetes and heart disease and things as well too. So it's really important to take a proactive approach, and definitely young people are often at the time where they're developing their own habits independent to what's going on necessarily at home. So there's also inequities and disparities between European and Pacifica youth as well too. Again, in these areas, it's interesting that there is some increase around smoking, which is something that we have to watch again with the next cohort, and what that means. I know that we'll be looking at vaping as well too in the next cohort, because that's an emerging area that we're seeing with young people, that they're not starting smoking but they're starting vaping, and it really is around inconsistent contraceptive use, and in our younger ones not using seatbelts while being in a car. So again, what I talked about around mortality and what actually causes death in our young people. So asking about this and reinforcing this as being important is something that's needs to be remembered all the time. And then there's emerging things. So this is a big cohort study that was done through the AUT, and it's the biggest Pacific families cohort that has followed people from birth 2000 onwards. So now we're getting 18-year-olds, but 1,000 children that were born in 2000 and their families were followed significantly over that period of time. And this was an article that was released in July this year, which showed that half of 14-year-old Pacific youth have gambled at least once in their lifetime, and 1 in 27 of them were problem gamblers already at the age of 14. So you need to be aware of this in regards to questioning in terms of gambling and the risk factors around that as well too. So there is some association around gang involvement, bullying at school, and having a mother who's gambled. So what do we need to be worried about next? Gen Z, or what comes after Gen Z? They might have to make up a new alphabet like the license plates where it's A, B, A, C. Anyway, what should we be aware of? So I'm going to touch a bit more around pornography. So gone are the days where you needed ID and to get into a back room at the video store, and gone are the days where you had to buy a magazine that was sealed that then was hidden under the bed for a period of time and only brought out at certain times. You know, it's available, readily available 24/7, no ID required from any kind of mobile device or computer. And I think that's the difficulty with cell phone access. We try and talk to our teens regularly, and our 14-year-old was shown porn when he was 13 by a schoolmate on a mobile cell phone. And so it's really having discussions and talking openly and frankly about it. You really need to be talking about what real relationships are when young people are now 9 and 10, because you never know when it's going to be that with the access of cell phones and inquiring explorative minds, when and where they're going to come in contact with this, and understanding too that it's an industry. You know, for young people, they need to understand, just like on the movies that they go to watch at the movie theatre, you know, these are paid actors that on average men will last a long time in this industry, but women will last not very long at all, and that actually it can lead to real issues for people in terms of sexual dysfunction, not being able to maintain an erection, premature ejaculation, things that actually are quite difficult to overcome with someone who's experienced porn addiction. And this is well recognized now in New Zealand, and I've put a website there that's just been released in the last couple of weeks alongside ACC. This is around their healthy relationship stuff, but it's where parents and young people can get information around pornography and real facts and figures and things like that. So have a look. I've had a brief look. The imagery is youth friendly, and it's nice short snippets, so it's kind of easy to navigate, but have a look at that. So gaming, the other thing that people often ask me about in terms of HEADDSSS assessment, that doesn't come under HEADDSSS assessment.
No, we're going to have a G on
positive? Yeah, that's right. Is it positive pro-social activity or is it an addiction? And it's funny because I'll have parents coming in thinking it's an addiction and actually it's probably positive pro-social activity. And you need to be aware of trends which are continuously changing. I think GPs really loved when Pokemon was great and the thing that everyone was doing because everyone was outside on their phones and walking around. But the latest thing is Fortnite, and Fortnite is a game that can be very addictive, that you can spend lots and lots of times on, but it is actually pro-social because you're often working in teams and you're having conversations with people, and my teenagers will have conversations with their cousins that live in Australia and in the US and all over the world, and actually they know more what's going on around the place than we do sometimes in that sense. And so yeah, it's been aware of what's up at the moment and having some understanding around that. And if they are limiting their use and they're participating in other things and they're doing well at school and all of those things, it's a pro-social positive activity for them to participate. But it is the wariness of timing and the fact that that can impact on other risks around weight and risk around future health issues as well too, but also be aware of addiction. So addiction is when it's reduced pro-social activities. They're not tending to play in groups. They're socially isolating themselves. They're starting to exhibit signs or symptoms of depression, as well as being very, very intent on playing a single game. And sex trafficking, I was going to talk a little bit more about that as well too, because I think this is important for us to understand. So this PhD student is really interesting looking at her research, and I'm only doing one slide on this. She presented a whole presentation on this at a recent youth conference that I attended, and she is a social work PhD student specifically. What she did was she surveyed general practitioners across the country around what their understanding of sex trafficking was in New Zealand, and it was really interesting to see those results. But then actually what it is about mainly affecting young Māori within New Zealand. So mainly vulnerable young people who've either become homeless or disengaged at an early age, and then it's often been instigated by either a trusted partner, boyfriend, girlfriend, some other significant other, or a family member that have actually instigated the sex trafficking occurring. So where that young person is having sex for money, but they receive none of the money for themselves. This is that is the definition of sex trafficking, and it's occurring well within New Zealand. A lot of it is gang related, and it's around actually the young people that she interviewed talked about it was a form of protection, because if you were doing sex trafficking, then you were less likely to be raped. So, there are some really interesting beliefs and stuff of this group of young people that are within our country that are being vulnerably affected by this. It's not covered by legalization of prostitution because it sits outside of that. And it's really important for us to become advocates in some way and to become aware, and if you are suspicious of this, ask the right questions around this, because at the moment there's no real support services. These are often young people that don't fit criteria of women's refuge, yes, but in some ways beyond that, there's significant PTSD associated with this, and ACC sensitive claims can help, but there's no kind of specific services available nationally to tackle what these young people have been through. So just being mindful that this is an issue within New Zealand.
Aniva, can I just interrupt you? How do you suggest asking about something like that? How do you bring up this type of topic?
You can be quite, straight to the point, in the sense of, have you ever had to perform sexual acts for money? And Have you ever been forced to have sex with someone else and someone has received payment for that but not you? You know, like those are quite, I mean, they're quite direct.
Yeah.
Yeah, those are quite direct, but those are really the definition of, I mean, you can document sex trafficking if they say yes to either of those ones. I mean, some of the interviews, so in the PhD you can, because everything's been de-anonymized, but she's used real cases in the sense of what young people have talked about. And so from the top of my head, one that I can remember was a young person whose boyfriend sold her virginity for $500 to an elderly guy. And you know, there's a lot of pedophilia that you know, young ones being asked to dress up to, like young ones that are say 17 or 18 being asked to dress and look younger, so they look like 13 and 14-year-olds. So you know, there is definitely still some really, and this comes under criminal activity. It's a criminal offence, but there's not a specialised department within the police about it. And I think that this PhD student is quite an activist in trying to raise a profile by getting this research out there and trying to, again, women's refuge is, I think, backing this being promoted and more widely spread so that we actually understand what the issue is. It's because I think the difficulty and the assumption was by general practitioners, everyone thought about, you know, made assumptions that it was Asian or African refugees that were being imported and being kept, you know, under lock and key in situations, and that's not it at all within New Zealand. That's not what the research has found. And so there's a marked difference in our understanding and our views with what's actually happening in New Zealand. Yeah. So it's educating ourselves and then finding the right words that we're comfortable with using talking to people. Sorry, was there another?
No,
question?
keep going ahead.
Okay. So yeah, I just thought I'd put this up. So what's next? Well, Japan's struggling with young people not even wanting to have sex anymore. So, you know, people addicted to animes and having intimate relationships with robots and stuff like that. So who knows what's next in our future. Brief interventions. I'm just going to do a quick slide in terms of 50 minutes because I'm mindful our time is getting low. So role playing I find is quite helpful with young people. That can be done really easily. Often our young people are not equipped because they're a texting generation. So actually having them verbalize what they think in their head they might say, but doesn't actually come out that way when they're in the situation, having them do it and actually feel comfortable with the words that they're going to use when they're next in that situation is a good way to protect young people from finding themselves in risk and not being able to get a way out. Focused acceptance and commitment therapy. I'll do a plug for Bruce. I did this training a little while ago with Bruce Harrell, and it's definitely helpful again in terms of brief interventions around young people that are a bit stuck. Doing contracts, and sometimes I will do a contract with a young person between me and that young person, but sometimes I'll encourage the family to do a contract as well too. You know, if there's sometimes it can be, young people need concrete things that they can hold on to in regards to consequence, and contracts are a really good way of making that black and white for them between a parent and a child. The other thing is smarter goal setting. I've also done the healthy conversations training, and I'll put a resource up that I will sometimes use. It's really easy for young people because it's just 1 or 2 word answers in the boxes, and again, a quick tool that you can use within settings. And we all do motivational interviewing. There's some good evidence around mild to moderate drug and alcohol use, around using a pros and cons list, and then that eliciting self-directed behavioural change by the young person, or for you to identify if that list is not is a bit unbalanced, then actually they might need a more professional referral or treatment program referral. So that's just the smarter planning for change. I'm not, you know, people may already be using this themselves, but it's a nice, handy, colourful tool that youth seem to respond to quite well in practice. And it allows you to kind of follow up with them, because often what we'll do is we'll scan this into the notes, and then when they come in next, we can kind of touch base and see how they're progressing and stuff with it.
Aniva, there's been a question that's come in that's asked what sort of timing would you look at for follow-up for a youth that you've seen, and there have been things that have come up in the consult that you'd like to follow up on. What timing are you looking at for that?
It depends on how significant those things are. So often with mental health, I'll usually give them it may be a couple of weeks, or I might do a phone call at a week just to touch base, depending on how worried I am around a young person. But for other things, you know, maybe a month to 2 months. In terms of touching base and seeing how they're going. Usually with most of the smarter goal setting, it's giving them a good 4 to 6 weeks to actually implement something, because you don't want to bring them back in a couple of weeks and they felt like a failure because they haven't been able to actually get into it or do those behavioural change stuff. Yeah. So
give them some time.
That's right.
There's a few questions that I think we'll quickly run through before we better sign off, but one of them is along the lines of what, in terms of numbers and the causation of a suicide attempt, the numbers related to depression versus deprivation or discrimination that can cause or lead to a suicide attempt. Do you have any idea around the numbers between those two? I guess the mental health side versus the deprivation and side of things.
Not off the top of my head, but I think the difficulty is that a lot of, you know, they've done a lot of post reviews, and we know with young people, a lot of successful suicides are not necessarily planned, and there's usually been a trigger event. There's usually been something. It's not that they may have had grumbling depression for quite some time, but actually what's occurred around a suicide is it might have been something significant that's just done the trigger.
Yeah.
And commonly in overseas research, it's around relationship breakups.
Yeah.
So, you know, that's one of the common things that can contribute with young people.
Yeah. And so to be aware of that, I guess, when you are talking to one of your patients who may be going through something like that at the time.
Yes, yeah.
There's been some discussion about using the HEADDSSS tool, and someone's talked about how do we not overuse it, and I guess some of the things you've talked about already involve sharing those notes with your colleagues, so you're creating that team that you've talked about, and with the school-based nurses and things like that, trying to make sure that there is access to common files and note systems. The other question has been how often would you review it? So I think at one point you said you'd do a one for a 13-year-old, and then obviously that's going to be very different to a 17-year-old. So how often are we looking at repeating it for a child, so it's not feeling like it's losing its shine?
Yeah, I mean, and it's different. It's around, obviously, I had a few cases, but we're not going to get to them. And I think it's around still addressing the things that the young people come in with, and those things that they come in with might actually trigger what you do around their HEADDSSS assessment and what you do explore with them. The other thing that I was thinking is that actually it's a whole, it's not our topic tonight, but the other piece of research that I'm participating in at the moment is the youth chat tool, and that is around web-based screening. So actually putting it back in the young person's hands around doing screening assessments that are more validated as such, like your PHQ-9s and behavioural scores, or sexual health screens that have been validated in young people, and actually being able to find out, is this important to them at the moment? And it might not be, and actually you may as well not spend time doing motivational interviewing on a person who's pre-contemplative. But other things might be something that they're wanting help with or wanting to address, and so that's a self-selected way. So that, but we're just in the middle of researching that and co-designing it from a kura kaupapa perspective as well too, in terms of having it in te reo and administering it in te reo Māori. Okay. So it's another presentation altogether.
Fantastic. We'll have you come back. There's a question here about other populations. So clearly your interest in research and expertise has been in Māori and Pacific people, but do you have any knowledge about the stats for other populations, so Asians as a whole, and how their relationship of their statistics versus Māori and Pacific, and how do they reflect within New Zealand populations?
Yeah, so I think there's a website earlier in the presentation which takes you to all the reports. So if you've got, which does look at Asian breakdown as well too, and around the health issues that are affecting young people in that sense. Okay. Our youth health peer review group a while ago asked one of our Chinese trainee interns to come and present around, because again, who better to present it than young people themselves as well too. Because we wanted to understand more. We were seeing a larger population of international students, and how do we, again, cater our services to better meet their needs and understand cultural nuances that they come with as well too. So I think in your own areas you can call on people who might have that expertise to learn from, and that was a really helpful presentation.
We'll make sure that we'll make sure the link to that website we'll put underneath the webinar when it goes up on the Goodfellow site, so that you'll be able to directly access that as well. Very quickly, a couple more. How do you ask about gambling, and where do you direct them for help once you've discovered there's a problem?
There's websites available around problem gambling in New Zealand, and there's an 0800 number as well too. So it is around kind of, again, it's that exploring around risk factors. Do you have parents that gamble? You know, do they buy lotto tickets regularly? Do they play the pokies on a regular basis? Do you as a family go to the track as well too? My dad used to grow up doing that as a Sunday activity with his parents. So it's just like understanding what families are experiencing, and then if you find that they're saying yeah, then you can just say, oh, have you ever gambled yourself? Then that leads into it, and most young people will talk about, again, they're very savvy, because the thing is, you can gamble online. You can do this from your couch at home now as well too. Play poker, you can do gambling apps. There's a whole lot of accessibility and availability. So, and the difficulty is that there are people that make careers out of it as well too. So again, young people often will see this and think, gosh, could I make lots of money? You know, and that's the other thing is that, you know, does that create financial strain for themselves and their wider family?
And I think in terms of asking, it sounds like for most youth, your approach is being direct and speaking plain language, and asking them directly about things that may be a problem for them. Yeah. The sex trafficking, very last question. I'm sorry, there's so many things that have come through tonight. And so we've hopefully gone through most of the questions here. The last one here is, do we know whether the sex trafficking is both an urban and rural issue, or just in the cities? And what do you do next if they do declare, or they do say yes, that this has been happening?
I think it's really important to get them safe, especially if it's actively occurring. And I don't think there's a discrepancy. Like, I don't think there's, from what I saw of the research, there's no. There are actually pockets in New Zealand. There are high areas, and you would understand that there are low deprivation areas, like our low income, low socioeconomic areas, our high deprivation communities where this is occurring.
So that can be in a rural position as well as in the cities.
Yes, that's right. Yeah. I think her interviews were Wellington-based, East Coast, rural. So, she had quite a wide spread of people that came forward and were willing to share their stories. Yeah.
Look, thank you, Aniva. It's been amazing, and hopefully everyone, we've got through most of your questions here tonight. And Aniva's just been fantastic. There's so many tips that you can take and start using in your consults when you see a Māori and Pacific or any youth that comes in, and using that heads assessment as a discussion tool. I really like that tip of this is not something we should be using as screening. This is actually to create conversations and start opening up that dialogue. So thank you so much for coming tonight, Aniva, and we'll sign off now. Thank you everyone for watching.